تمام دكتور، نبدأ.
يلا بسم الله الرحمن الرحيم. I see eight تقريبا eight كلكم ما شاء الله interested in cardiac surgery ولا you're just seeing يعني if you would be interested أو لا. ألو. طيب إن شاء الله يعني at any point of this presentation if you have any questions it's an interactive session. The point of it is just to have a clear idea about what is the reality of cardiac surgery. I'm الوليد الثبيتي resident R5 في مستشفى الملك فيصل التخصصي في الرياض. Just small introduction. I graduated around 2020 COVID time. Started residency at King Faisal Specialist Hospital and continued to work there till now. Uh, During residency, I took multiple roles in our program. Initially, I was just part of different organizing committees for mostly academic activity for resident. Last year, I was working as the deputy chief of cardiac surgery for our residency program. طيب, what is cardiac surgery? Cardiac surgery is a specialty that deals with ثواني بالله. This is a specialty that deals with any procedure that involves either the heart or major blood vessels that carry the blood to or from the heart. So our work extend so basically all organs within the thoracic cavity except for the lung and trachea and the spine, obviously. A lot of people think we are only working on heart and valves, but as you go to more tertiary centers, you see uh, cardiac surgery being done on aorta, IVC, SVC, etc. طيب, what is the environment that usually you'd see cardiac surgery working on? Well, we work in operating rooms. As you can tell from the name, cardiac surgery ICU, we have extensive role in the surgical ICU. So your role is not limited as only a surgeon, but also a critical care physician. You work in MDT, different MDT meetings, and depending on the hospital, you at times you will be doing daily MDT meetings. You do wards and clinics, like a list of specialties, and you have emergency calls, whether it's either emergency for cardiac surgery patients or emergency procedures, life-saving, like inserting mechanical devices, etc. The subspecialty for cardiac surgery, you have coronary artery disease, which takes the bulk of general cardiac surgery practice. And the bulk of procedures, as we will discuss later. You have also valvular heart disease. You have aortic surgery, and the difference between aortic surgery and valvular heart disease. In aortic surgery, you're specializing in management of the aorta itself, or the aortic valve and the aortic root, which is a completely different subspecialty. But when you say valvular heart disease, you're mainly talking about mitral valve, tricuspid, as well as some aorta, but that's the bulk of the practice. Congenital cardiac disease, this is one of the two main pathways that you can actually take as a cardiac surgeon. And the last, which is very exciting, and newly developing subspecialty, heart failure and mechanical circulatory support devices. We mean durable or temporary both. Uh, with coronary artery disease, nowadays there is special fellowships for coronary artery disease. As it, you know that it's most common workload, but there has been a lot of advancement within CABG. Some people would do it off bump and on bump. You'll do multi-arterial. Usually with CABG, the typical practice is to do it on pump on cardiopulmonary bypass, which is the device we use to facilitate our surgery. This is what allows us to work on the heart to make it motionless and bloodless. But people who specialize in cabbage may be trained to do it half pump without the device or do it with full arteries. Usually, your targeted population are elderly, diabetic, and nowadays are very high risk patients. Aortic surgery, as we mentioned, it's the branch that deals with dissection, aneurysms, or even genetic syndromes. These are usually very high risk surgery, whether emergency or none. You also work on the root, the aortic root, the arch, and you do procedures such as frozen elephant trunk. Heart failure, this includes either heart transplantation or you do ventricular assist devices. These are the durable devices that you can insert that takes the role of the heart, whether LVAD or more temporary support like ECMO and Bella. This requires extensive knowledge in ICU, and it's usually a team endeavor. So you'll be working with other heart failure specialists like cardiologists, nursing staff, etc. And usually you would deal with patients who are almost either dying or so that's the type of environment you'd be working in. Congenital cardiac surgery, I'm sure many of people are aware of it, and usually all cardiac surgeons who join cardiac surgery want to do neonatal pediatric surgeries, but by the fifth, sixth year, they hate congenital and go to adult. It's usually very complex, and you'll usually you'll be operating on, especially complex procedures, you'll be operating on people from their young age, and you may do multiple surgeries for them throughout their life. Your typical day as a cardiac surgeon, usually you do very early rounds, sometimes starting 5 a.m., 5:30, 6, whatever, depending on the center you work on. Uh, you'll have long operations. ICU reviews throughout the day, whether in the morning, night, as you have multiple sick patients, clinics, and emergency consult. So now we talk يعني about some of the realities within the program itself or within your work as a cardiac surgeon. Usually it is ORs are very physically demanding and majority of that times they take they are يعني you operate for very long hours. You concentration that is required from you inside the OR is very high as uh, in cardiac surgery at every step, there could be a disaster if you make a mistake, and this can lead to patient death, which is very unfortunate. But also very rewarding if you like to work in such environment. It requires very high concentration to be able to pull this off, and usually it's a team effort. In cardiac surgery, you'll see the play of three main people who are the anesthesia, the perfusionist who are running our machine, the cardiopulmonary bypass machine, and the surgeon himself. And it's usually a collaborative effort to make it work. In ICU, your role is very critical as you'll have uh, in majority of big centers, you'll have ICU that is dedicated to you as a as a cardiac surgery department, and depending on the arrangement of the ICU, sometimes you may be the main decision maker for the patient care. Or sometimes it's a collaborative effort. Like in our center, we have the ICU team with CSICU consultants who are specializing in cardiac surgery ICU. But I've worked in hospitals where the ICU is being covered by the cardiac surgery staff themselves. So during on calls, you'll be covering the ICU, or sometimes some member of the team who would be doing the rounds daily on the patient. Sometimes it's the anesthesia taking care of the bulk of the work for the ICU, and you are the decision maker. So it depends. Usually, the cases you'll be dealing with either uh, routine cases, or sometimes you'll be dealing with patients who are quite very critical. Majority of the issues that we would see in ICU is basically bleeding patients, patients who have low output, who have different arrhythmias. Majority, all of our patients are ventilated, uh, and you'll have to deal with a lot of issues that arises from cardiac surgery. Uh, Usually, the on-calls, it depends on the center, but usually you'll have the maximum amount of on-calls. I'm not sure if you are aware, but in residency, uh, you're given a limit of 7 to 8 on-calls per month, and depending on the number of residents or the staff that is available. And you'll usually have all of these on-calls at the hospital. The on-call duties varies depending on the center, but usually you'll be dealing with acute dissections, tamponade, especially for patients that you operated on, and very rarely valve thrombosis. So, and occasionally you'll see your post-operative patient who you discharged will come back for whatever complication in the ear. You don't really deal with if I don't know if has anyone done any rotations before in hospital? What year are you guys? أنا forgot كلكم interns ولا students؟ أيوة. Which year؟ ما شاء الله يعني okay different years. Okay, if you have done any rotations in the hospital, I'm very sure you'll see a common uh, dislike among physicians that they don't like to deal with ER. And we one of the very fortunate things in cardiac surgery that you rarely have to deal with ER. Majority of cases, cardiac cases, usually is assessed and faced by cardiology service themselves, and then they will refer him to you. So if you don't like ER work, cardiac surgery is quite uh, nice for that. طيب. Now, when we talk about stressors and disadvantages in cardiac surgery, a huge advantage. طيب, one of the biggest things, obviously, is the emotional load that cardiac surgery puts on you. Even if you think you're not emotional, you'll at certain times it will hit you, especially with all the critical patients that you deal with. Sometimes you'll have patient dying despite your best effort. No matter what you'll do, you'll face that within cardiac surgery, and you'll have to have the difficult family conversations with them, sometimes even preoperatively to counsel the patient. There are conditions that carry very high mortality, and unfortunately, uh, to the patient themselves, sometimes they feel fine. They don't see the need for the procedure. It's not like cancer, for example. Sometimes at the moment they are okay. Obviously, the future or the prognosis for the condition is bad, but they don't realize it now. So you have to talk them into having such a big procedures that is quite risky. And if things don't go well or not as planned, sometimes you'll have to also discuss this with the family or the patient afterwards. The specialty is full of complications that will, even if the patient survives your procedure, he may have to deal with the complications post-operatively throughout his life. And then, obviously, as a surgeon, once you start operating, uh, now as a resident, I'm fortunate that all the cases that we work on, the person who's responsible is the consultant. So, and the majority, no, I'm not going to say the blame because you really don't really care about it, even if as a resident, but rather the feeling of that you took the patient to the OR, you worked on him with your hands, and then you ended up with such bad results. It never feels good. With the surgeon or whoever it is who's operating. Uh, and usually the bulk of that will fall on you later once you start your practice. Uh, Early training phase in cardiac surgery is very tough as well. You'll have your medical school, which is 7 years. But then after the medical school, usually people expect some a satisfying special or satisfying flow for his career. And within 4 to 5 years, he will start practicing medicine. And maybe by 6 years, you are a consultant already. But in cardiac surgery, you're expected to take at least 15 years to become an independent consultant. You'll be doing the residency, which takes around 7 years. Majority of the time, you'll be working 2 to 3 years after residency, which is now you are at year 10 and you're still not independent. And then you may do 1 or 2 years of fellowship outside. And that will take you somewhere between 10 to 15 years. And this is the average for majority of cardiac surgeons. Sometimes you can take even higher. Uh, uh, all of this training till you become independent and you actually finally start doing surgeries, which is the thing that you wanted from the start. Your early career will revolves around first getting the basics of cardiac surgery and then starting to assess. Majority of the time you'll be assessing, and depending on the program, we will discuss this later, but depending on the program, the training that you get, sometimes you don't get exposed to actual doing surgeries yourself as the surgeon till very late. So it has a very delayed gratification, and the learning curve is quite long for cardiac surgery. And as I told you, throughout your life, at least for 7 to 8 years, you'll be doing assisting more than operating, which is sometimes can be uh, sometimes it can be not encouraging for you. Uh, as I said, it will take you years to get the skills for cardiac surgery, whether it's not only surgical skills, but also management. I already explained to you before that the environment that you will be working on or in is quite varied. You'll be working in ICU and you'll be working in the surgery. And all of that takes a very long time to acquire the skills to manage all these conditions, all these critical scenarios, and you'll be shadowing people for a very long time. You'll see that in medicine, and this was one of the difficulties for me, especially. This is one of the things that I did not realize till I actually started working. By third or fourth year of my residency, I was seeing all of my colleagues in other specialties like GS medicine, family medicine. They were practicing like almost fully certified physicians, and they would be making large decisions for their patients or during their services. They would be running the service, and that is quite gratifying for you if you finish med school and you work for 2 or 3 years, and then now you are taking care of the service. It's quite for you. It gives you huge self-worth, but then you look at yourself as a cardiac surgery resident or trainee, and you're still junior, considered junior. I'll explain to you later the program. But till fifth year of cardiac surgery, you're still considered junior in the specialty, and you're barely making small decisions, and you're barely uh, getting into the specialty. So that sometimes can be difficult. Competitions and expectation. Uh, uh, Cardiac surgery has you don't have a lot of spots. Each hospital require only 2 to 3 surgeons, unless you're working in a very large center. But even in our center, for example, we have only 4 surgeons, 4 to 5 surgeons in adult cardiac surgery. So it is quite a competitive specialty. In order to work, you probably need a lot of certifications, you need a lot of training, and you need to be a good cardiac surgeon. And when you come and when you land on the spot on one of these spots, usually there is huge expectations from you as a cardiac surgeon, especially nowadays. Nowadays, majority of the AZ cases they are done in cath lab or with minimally invasive techniques. So although we manage a lot of patients, but all of these patients nowadays they're not simple. They are very high risk patients and they are very difficult. That's why it's expected from you. So, for example, I'll give you an example. Recently, we had two examples actually. Two surgeons who just graduated and came back from their advanced training. One was in congenital and one in adult. Now they are expected to work as a fully independent consultant. But if in the past, usually those people who would come back from this training, they will start with simple cases like cabbage and maybe simple, straightforward valve like an aortic valve. But this is not the reality nowadays. They are giving redo cases. They are giving cases of infective endocarditis. They are giving cases post-TAVI. In the congenital side, you'll be expected to do redo cases. There is a huge expectation from you. And last, you know, this is something very nice I saw. I picked up from a surgeon in cardiac surgery, not even cardiac surgery, in a lot of surgical specialties. We don't, يعني, you don't call it work-life balance, but because there is really no balance, but there is work-life harmony. You'll have to make compromises in your life and sometimes even in your work somewhat to make it work. Uh, in early on during your career or training and residency, uh, your the skill is hugely tipped toward your work because even if you finish working, you'll go back home, you'll start practicing on your surgical skills to get going. You'll have a lot of studying to do. As I mentioned, cardiac surgery, you'll be doing a lot of studying. It's not a surgical specialty that you'll work with your hands and that's it. You'll have to acquire skills or knowledge that is similar to a critical care physician to be able to work in ICU environments. You'll be reading and acquiring knowledge in cardiology to be able to discuss with cardiologists and actually understand what you're doing. And you'll also have to work on your surgical skills. So throughout your early career, it's very demanding. Usually with seniority, with the years, it improves. And this is uh, once you get married and uh, you get your family life and all of that, you'll need a supportive partner to deal with this issue. There is communication is very important, but you'll have to understand that you'll make a lot of sacrifices within your family or even your extended family. A lot of social events will be missed. And when we talk about it on a personal level, you know, majority of surgeons, not cardiac surgeons, but surgeons in general, especially these demanding specialty, they will have self-neglect exercises usually not existent. Sleep deprivation is very common. I remember throughout my first and second year, my average sleep was between 3 to 4 hours because you'd be doing either you're working or after you finish work and you come back home. I'm a person who really care about my outside of the hospital activities. That's why I had to sacrifice sleep in order to keep some form of social life or other activities that I'm doing or other interests. I think it's very reasonable to keep an interest alive. Some of our residents, they are musicians. Some of them are athletes. One of the newest residents who joined our program in East Province is a football player, and he's still active. He's playing at a club. I forgot which club. It's very reasonable. You can still maintain all of that, but you'll have to make sacrifices in another part of your life, whether your family, your social, whatever, or your personal life, sleep, and that. So, uh, when you hear all of this and you know it's very difficult, why would you join cardiac surgery? Uh, Cardiac surgery, you're doing surgery at the edge of physiology. All of your patients, and this is one of the one of these. This is one of the things that drew me and attracted me to cardiac surgery. Yeah. Everything you're doing, every step you're taking in cardiac surgery, you're altering different physiological, or you want different physiological adaptation, or you're changing the physiology of the patient, and that is so satisfying when you understand the physiology and then you change it depending on the patient condition, or you start doing things, especially in congenital cardiac surgery. In congenital cardiac surgery, sometimes they are inventing things on the spot to deal with whatever pathology they are doing. And that is very interesting. Uh, Cardiac surgery has a direct impact on survival and the quality of life of the patient. You have patients who's having chest pain, who's having severe heart failure. The patient is short of breath uh, the whole time. He's having symptoms with minimal effort, and you take him for a while. 2 weeks later, this gentleman is fully mobilizing, and all of these symptoms has improved greatly. Greatly. Uh, Cardiac surgery combines anatomy, physiology, ICU, and technical mastery. And this is another thing that personally was very attractive. I didn't like. I actually initially wanted to join medicine. I was interested in the knowledge part of medicine, but I wanted something that I would do with my own hands. And cardiac surgery has this very nice combination that you can do things with your hands and also work with your brain, which is something not all surgical specialties can provide. And in cardiac surgery, as some other specialties, seconds and millimeters matters. What does this mean? Your actions in the OR, sometimes you have to do actions within seconds. There are some complications that can occur. If you don't deal with them within seconds or minutes, you lose the patient. Uh, I told you at the beginning that throughout your surgery, there are so many steps that you can be doing from after, I'm not going to say from skin incision because that's a lie, but once you enter the sternum and once you enter the heart, that's when things starts getting dangerous. Every step, if you look at our books for operative techniques for cardiac surgery, usually the flow is like this. You open the chest, okay, you open the sternum, and then you'll see 10 complications that can occur and how to avoid them. And then you open the pericardium, and then it will show you different things that can go wrong there. You go, for example, in cabbage, you harvest the artery that you'll be using for bypass, and then it shows you different complications that can occur. So at every step, there is so many things that you need to keep in your mind, so things do not go wrong. So all of these times it matters, and millimeters matters because every stitch you're taking, everything you're cutting, you're working on very fine structures. In cardiac surgery, like in neurosurgery, we work with loops. These are surgical microscopes that you're wearing the whole time to be able to see what you're doing. So it's quite fine. Uh, you'll have the benefit of saving lives, although majority of people in medicine do save lives, but the effect of your actions is usually more immediate, especially if you're working during your junior years. You'll be dealing a lot with severe cardiogenic shock, and you'll be inserting a lot of ECMOs along with your assistants and your seniors. So you'll see patients who's dead, and then بقدرة ربي, plus all the things that you're doing and the ECMO devices or the resuscitation devices that you're doing, you save his life. You'll see the recovery in front of your eyes. And if you are professionally driven, uh, obviously cardiac surgery can fulfill this. Now, the questions that you would be asking yourself to see if to see if this or such specialty is fitting for you. And I think this is very applicable to all surgical specialty. Can you handle the long training and all the years and with the delayed gratification that comes from cardiac surgery? For me, in the first few years, this was a very bad point. It, it was very depressing in my third and fourth year where I wasn't doing any surgery. I was basically doing junior work. This is meaning I'm doing grounds, I'm doing notes, I'm basically just replacing electrolyte, and there is no gratification. I'm not doing real surgery where I thought I'm joining cardiac surgery. Can you work under pressure? It's very stressful environment. The stresses come not only from the conditions that you're doing. This comes from the environment that you're working on. In the ICU, the ward, you have a lot of usually uh, the department of cardiac surgery is usually very small, and the cover coverage that you're doing, you're covering a lot. You're covering the floor, you're covering the clinic, and you're covering ICUs. Sometimes all of this is covered by you alone, as a sole resident. And it is quite stressful. There is a lot of expectations from you to do research. There is a lot of expectations from you to be studying. And there is a lot of expectations from you to join artwork. And all of that is can be very stressful. And can you accept responsibility? In cardiac surgery, there will be moments where you leave the OR and go to the patient family and you tell them clearly, uh, we did this surgery and the surgery went wrong, or something wrong happened. We did this, and your patient either died or he's in a very critical scenario. Some people cannot really face such responsibility or do this. It's quite difficult. But in cardiac surgery, you have to do it. You have to go to them and explain it clearly that, and this is a recurrent scenario, especially if you do high risk cases. Preparation as a student, I would advise you to shadow surgeons, go do electives in cardiac surgery. You can attend operations, but I think the best thing that you can do as a student is actually join with the residents and see their daily life, because this is what you'll be doing for the next 10 to 12 years of your life. Seeing what surgeons are doing, this is your end career, which is, I'll tell you this, and I think cardiac surgery can be very comfortable specialty. Once you become a fully independent consultant, you can have elective cases. You can join a small center where you do 1 to 3 procedures a week, which is very simple. You have good control over your life, especially if you're not a center that deals with a lot of heart failure, acute conditions, and all of that. Because I told you, in cardiac surgery, you're not dealing with emergency medicine. So you will not receive any consult. So it can be very easy, and you can have control of your life later on during your career. But at the beginning, which is the bulk of your training, 10 to 15 years, as I said, it's going to be miserable, and you're going to be doing what you'll see residents do. So I would advise you, uh, if you are interested in cardiac surgery, to join residents, and don't undermine this 10 to 15 years. You think that you can be patient through it, and then at the end you'll get to it. But by third, fourth year, you'll be so depressed because your progress is very slow. When you look at your peers, they are much better. And that sometimes can be discouraging. And join research projects. Uh, Why I chose cardiac surgery? I told you I wanted to go to cardiology. I liked cardiology during my med school, but I always was not satisfied with going to a medical specialty. I always wanted something surgical. I tried GS. GS was not really mentally stimulating. So I had I watched cardiac surgery before, and I hated it during med school. By fourth year, I excluded it as one of my specialties of interest, and I decided to join GS. And then I had the revelation by my fifth year or sixth year, I think, fifth year, that if I like cardiology and I like general surgery, I probably will like cardiac surgery. So I gave it real thinking, and I did around 2 months of electives in cardiac surgery, and I read about the specialty, and then I realized that this specialty is actually very suitable for me. I liked what interested me in cardiac surgery is the amount of knowledge and mental stimulation that you get from not only inside the OR but also outside of the OR. And obviously, you'll do all of this fine surgery. The key challenges during training that I faced, as I told you, the slow progression was very depressing, especially in my third, fourth year. Now, I'm progressing well in my fifth year, and I think it's very reasonable. And obviously, this is going to be different from center to center, as we will discuss later. But the slow progression is quite depressing. Actually, in our residency, in our residency program training last year, around we are not many residents. I think The whole program is around 50 to 60. No, not 50, 60. I think it was 50 residents. Only last year we had around 10 residents leaving the program, and they were residents from first year to third year. And they left it for these reasons. Some of them obviously had better opportunities outside, but that's only one or two residents. Majority of the residents either they did not like the progress, they did not like the slow progress. It was not gratifying for them. So there is a high drop rate in cardiac surgery, and that's why I told you you'll think you can be patient throughout the first years, but it is quite depressing because in order to be patient and you deal with all of these difficulties, at least you want something in return. That is you want to see a light at the end of the tunnel, but in cardiac surgery, unfortunately, sometimes you don't see this light. So you'll just have to walk throughout this tunnel, and maybe 10 years down the line, you'll see the light. What surprised me the most, I'm not sure. I don't remember something was shocking for me and surprised me, but I think what surprised me the most is that for me, I thought I'll be patient and I didn't think that I was reading about these things that I'm telling you now. That is difficult, long training, all of that things. I thought that it's going to be easy and I'm going to deal with it. This was my personality before, but actually experiencing it firsthand was quite shocking. That sometimes you read, for example, about toxicity or the difficult work environment in cardiac surgery. And do you think the toxicity, you go as a student and you go to the OR and you see the surgeon or the consultant shouting at the resident and you think this is the toxicity. This is actually the least of it. And this is nothing. And you actually, as a resident, we don't mind it that much, but you see toxicity in different ways. The environment itself, and sometimes the tough things that you experience are things that you did not consider till you started working as a resident, and not the things that you'd read or you expect. But now let's talk about the cardiac surgery uh, program in Saudi Arabia. And if you have any questions regarding this, because this is very important for you if you're seriously considering cardiac surgery. These are the centers, and we have around 10 to 11 centers. Why I say around? Because every year, sub-centers will shut down their acceptance. Sometimes some residency programs will accept every other year, but majority of centers they will accept yearly. Uh, and these stats that you see for the number of residents, this was around 2 years ago. I had another updated one, but with few residents are leaving the program, the stats are not accurate. But currently, we're having around 50 residents in our program. The largest two programs uh, is King Faisal Specialist Hospital and King Fahad Medical City in Riyadh. Uh, King Faisal Specialist Hospital in Riyadh, actually, we shut down our program. Uh, for the past 3 years, we were not accepting any residents, and this is very important. And this was a mistake that I saw multiple interns making with their elective rotation. Usually, I would advise you if you are an intern to join or take electives at the center that you want to go to, because I've noticed that majority of people who would get accepted are usually the people who rotated in that center. In my year, there were 8 candidates, and they accepted 2 people. Me and my colleague who we rotated with them. I took 2 months in King Faisal Specialist Hospital, and my colleague took 1 month with them. And all the subsequent years, it has been the same pattern. So if you really want to go to cardiac surgery in a certain place, go take electives there. And make sure that at your year, they are accepting residents. So ask beforehand the residents or whoever, get in contact with them that are they accepting any resident there. For example, in I think you guys في العنيزة صح؟ انتم القصيم I don't remember. يعني ممتاز. There are no centers that have residency program. So realistically speaking, if you are gonna do residency, you have the option of either Riyadh or Dammam, and maybe if you want to go to Al Medina. In Medina, there is only one center. For Dammam, only one center, or Al Ahsa, another center. In Riyadh, they have three centers. Well, two now. King Fahd or Prince Sultan Cardiac Center, or the military hospital. These are the two centers in Riyadh. So in Riyadh, they are accepting only two residents. So this is something to consider. These are the number of cases, and you can see there is a variety of cases or number of cases. The average for all centers is around 600 cases. All these centers that have lower have been shut down. King Saud University Medical City, they are now graduating the last few residents. King Abdulaziz University, they are also graduating the last few residents. They have been both shut down. Uh, King Faisal Specialist Hospital, King Fahd Armed Hospital are both two active centers in Jeddah. King Abdullah Medical City, this is a center in Mecca, and they are very active and they have very number of cases. Medina Center is also the same. Al Ahsa is a small center, and they have a few number of operations. They are doing around 400 cases a year, which is quite good, to be honest. And they are accepting residents every other year, except for the last 2 years. I think they accepted two residents. Saud Babdan Cardiac Center, this is a center in Dammam. Prince Sultan Cardiac Center, this is one of the biggest hospitals for cardiac surgery, especially adult cardiac surgery. I think this is probably one of the best training centers في السعودية عندنا. King Faisal Specialist Hospital Riyadh, we are doing around 1,300 cases, more or less. But don't list this number fully. Majority of cases in King Faisal Specialist Hospital are very complex redo cases, and majority as well as they are congenital. So if you're thinking about adult cases, we're probably having less, maybe around 500 to 400, and the number of cases that is suitable for residents is even less than that. King Fahd Medical City, they have around 800 cases a year, and it's quite good. Residency program عندنا في السعودية, it's 7 years. 5 years you are a junior, and only the 2 years you are considered senior. And you think, okay, so in reality, it's 4 years you're junior, fifth year to sixth year you're in an awkward spot where you don't know whether you're a senior or a junior, and then by seventh year you're actually senior. And this is how people will deal with you. And these are the tasks that would be expected from you. You're gonna cover first and calls depending on the center for maybe 7 years. The whole 7 years you'll be covering first and calls. In our center, we are covering first and calls up to sixth year. Previously, it was fifth year or fourth year, but once we shut down the program and we have a few number of residents, now we are covering till the sixth year. In the past, we had two exams, which was very nice. You don't have the concern. You're not concerned about yearly exam that you have to take to pass. We are only taking two exams. One is during your junior years, the 5 year, and the part two is the final exam. However, last year we had a trial of an OSCE examination. Uh, Although I don't think it's going to be an OSCE examination as we discussed with the scientific committee, it's probably going to be some form of other examination, maybe OSPE or whatever. But they are planning to have a yearly evaluation, yearly examination to pass. The program in Saudi Arabia is consisting, it's divided in three divisions. The first 3 years, these are your basic surgical training years. You'll be doing GS, you'll be doing not a lot of cardiac surgery, maybe a total of uh, around, I think, 3 months of cardiac surgery. And you'll do a lot of ICU, maybe more than 6 months of ICU. You'll do cardiac cath, you'll do CCU, and cardiology, you'll do echo, you'll do anesthesia. Why is this important? This is also one of the things in cardiac surgery. You'll finish maybe 3 years without even seeing any cardiac surgery being done, or you'll only come to see as someone who would observe. Majority of people who would get the breast in residencies and not like it is usually in the first 2 years, and even by then you did not see cardiac surgery. So it's the time that you actually see cardiac surgery and you know you love it or hate it is sometimes by the third year. And the solution from our program was to divide the cardiac surgery uh, rotations. Yes, it was total 6 months. We took 3 months as the first 3 months of our residency because we noticed that some people would wait for cardiac surgery till the third year and now they hate it and then they drop by the third year. And that's very quite unfortunate. By then you wasted 3 years. So it's nice to take it in your first year to know whether you like it or no. And then after your basic surgical training in the first 3 years, you'll have 2 years, which is R4 and R5. This is your junior cardiac surgery rotation. You'll do around 1 year and a half adult cardiac surgery, and you'll do 6 months in pediatric cardiac surgery, and then you'll do 6 months uh, as senior in vascular or thoracic. And your 6 and 7 years, this is the senior cardiac surgery years. You'll do majority of your rotation is basically adult cardiac surgery, and you have around 6 months where you have the option to do whatever elective that you want. Requirement for acceptance. I'm not gonna lie. Probably you know the requirement better than me because now it's been around 6 years. But in the past, obviously, you need to take the SMLE exam. You have to have good GPA, good CV, and research and whatnot. Uh, the GPA depends from one year to the other. Sometimes you'll have lucky years where not many people are interested in cardiac surgery and the GPA is going to be very, very low. And you think it's so easy to get into cardiac surgery, and we see it. We don't have a lot of interns who would come show up for electives, and you'll have different years where our department is full of interns, and in these years is where the GPA would shoot up to the roof. So it's quite variable. I would advise you to go see the GPA requirement in the past 2 to 3 years and try to aim uh, for a GPA that is higher than that. Your CV, you'll have to show on your CV that interest in cardiac surgery, whether that is research in cardiac surgery or cardiology. It doesn't need to be in cardiac surgery, but at least in cardiac science. And you'll have to do some rotations in cardiac surgery. If you're not doing any rotations in cardiac surgery, it's going to be a big question mark during your application. I think if you want my advice, the best thing to do uh, is take electives. Take a lot of electives. All the residents that got accepted, they took a lot of electives. And even if you fail to join residency within your first year, you'll get a better chance to join it the next year if you have electives. Fellowships in so far in Uh, here we don't have any fellowships. We in King Faisal we are trying to establish a new fellowship program for robotics and minimally invasive, but this is gonna be maybe next year, and still it's a question. There is a huge question mark whether it's gonna be approved or not. Majority of people they would go to USA and Canada. Some people would go to Europe, and some people would go to Australia, especially for congenital. All the huge centers here they would put a high value or they would have high regard for people who had fellowships done in USA and Canada. So this is something to consider. Although you can go for Europe for some niche fellowships like robotics at the beginning. All the robotic surgeons were trained in Germany. Heart failure is also very excellent in Germany. Congenital was a good a pathway in Australia. But all of these things are things to consider, but I think it's very far from training. Some misconception about cardiac surgery. A lot of people think that all we do is CABG, but the unfortunate reality is the last CABG that I've done was maybe 1 month and a half ago. A majority of cases are not CABG. They are different complex operations. Depending on the centers that you're practicing in, you'll have different operations. You have to know that the statistics that you'll be seeing, like the ones that I'm going to be showing you, these are taken from US first. And second, in US or even here, we have a lot of centers that do cardiac surgery, but all of these centers, they would only do CABG. So they have very large volume of CABG. But then they would refer to you all the other cases. So in big centers where you actually would get trained in cardiac surgery, yeah, these are referral centers. So you'll not see cabbage and you'll see a lot of cases that involve valvular operations. You'll have maybe devices depending on the place that you're working on. You'll do minimally invasive aortic operations and sometimes congenital. But if you look at uh, statistics from US, the bulk of operations were actually indeed cabbage. Of around, this is only for adults, not congenital. These statistics are taken from a Society for Thoracic Surgeons. This is a database that is updated yearly. These statistics are from 2023, if I remember correctly. There is another update that has been done in 2024, but I don't have the article for it. But it's basically going to be the same. Majority of cases, maybe around 70 to 80% of the bulk was cabbage, and the rest were different, either AVR, MVR, MV repair, whatever, or combination of surgeries. Uh, this is another table that I brought from another article, which is something very nice I wanted to show you. If you people have done this relates to another misconception, cardiac surgery. A lot of people think that it is a dying specialty. That majority of the work that we do has been taken by the interventionist, but it is the opposite. Uh, it's true that they are taking a lot of simple cases and straightforward cases, but this doesn't mean that your work as a cardiac surgeon has been diminished. It just means that you're dealing with completely different population. In the past, you would face people who are young doing cabbage or patients who are coming for aortic stenosis and you do aortic valve replacement, that's it. But actually nowadays you're dealing with complex cabbage patients, you're dealing with complex valvular patients who maybe did TAVI or the transcutaneous aortic valve implantation, and now he's coming for a redo case. Obviously, uh, you can do it interventionally, but the majority of these cases they are referred to you as a surgeon. So the stakes actually has been raised for you as a cardiac surgeon to be operating on these patients. It has been getting more complex. That's what I meant. So in the past, when I told you it takes 10 to 15 years to be a fully independent consultant, there is a huge question mark whether that is even enough or no, since you're dealing with more complex patients nowadays. If you look at, I'll show you different statistics from different papers that is talking, or it's showing different number of cases across the years, and you can see from 2006 till now, the number of cabbage surgeries has been basically stable. And if you look at this, the statistics has been taken from the 2023 database for adult cardiac surgery. You see that the blue, which is the isolated aortic valve replacement, it has been decreasing since the introduction of TAVI, or the interventional answer for aortic stenosis. And you can see TAVI cases has been shooting up. But now you see there is an increase of isolated SAVR. This is because nowadays there was some excitement about the introduction of TAVI, and maybe not all people would know all the proper indications for using TAVI versus SAVR, but now it's more clear to when to use which modality, and now it has been stabilized. The case of aortic valve has been increasing slightly and TAVI decreasing somewhat, and as I told you, this is only showing isolated TAVI and SAVR. Uh, this is a paper that was done in Korea, and it is about projections of demand for cardiovascular surgery and supply for surgeons. It's the author of this paper. Uh, he looked at the statistics and the patients that would presented in his country, and he saw this trend or a change over the years. And then he calculated for the expected change of population by 2040 240. So after maybe 14 years from now. And the when he compared to 2014, he has yani his calculations, he's expecting to have the population coming for cardiac surgery to be increased by 85%. And then when he looked at surgeons uh, that are doing the surgery, he had different scenarios, but in majority of scenarios, uh, his projections are mentioning that the number of cardiac surgery being trained now are not enough for the increase in cardiac surgery patients. So in the future, you'll still be needing a lot of cardiac surgeons to be able to supply for the increased demand. Here we also have made Dr. Farid Khogar have made some statistics about the need for cardiac surgery and cardiac surgeons and the number of cardiac surgeries expected in 2030, but this article has not been published yet. I tried to get it from Dr. Farid Khogar and Faisal Ghamdi for you, but unfortunately they're still working on it. They have been working on it since 2022. This is the first time I've heard about it. Till now, they have not published it yet. So that's the end of the presentation. I hope they didn't take, I took around 1 hour. That was a long time. Sorry. Any questions? Do you think, I think, what do you think it increased the need for cardiac? What do you mean? After open the mic, you can ask.
السلام عليكم.
وعليكم السلام يا مرحبا.
أه، دكتور، هل تعتقد أنه 2030 راح يكون في زيادة باحتياج الجراحين؟
Okay, so there is a concern from cardiac surgeons here, or some of the senior cardiac surgeons that was raised in different conferences that we are training a lot of cardiac surgery residents and there is not a lot of spots for actually practicing cardiac surgery, which is true at the moment. After there will be a huge number of residents coming from outside of the kingdom and even here. And uh, maybe the centers initially will not be able to accommodate it, but if you look at statistics, it's showing the opposite, that we will be requiring a lot of cardiac surgeons, and we're not training them. But as things stand now, there is a huge number of residents that are being trained, and not all the spots are can accommodate them. And this is not because of the decline in cases, but rather because at the moment we don't have good developed programs for cardiac surgery. Maybe only few. But so I'll tell you about the situation in, for example, in Riyadh. Jeddah and the western area is covered by Mecca and Medina and Jeddah. Jeddah, Mecca, Medina, yes. All of these cities, they have cardiac centers that they are operating, and they are covering the region around it, like Yumba, Taif, etc. Eastern province, this is covered as well. They have the centers. Now, when you talk about Qasim, the north, south, Najran, Jazan, Abha, Baha, whatever, there are very few centers that do cardiac surgery, but majority of these centers, they are not working. They are not doing large volume of surgeries, maybe once or twice a week at maximum, and they are only doing simple cases. But if you look at the patient population that is coming to us in Riyadh, we are not seeing people from Riyadh. We're not treating people from Riyadh. We're treating people from all across the kingdom. So In the future, if you actually open more cardiac centers, especially in these areas, you'll be needing a lot of cardiac surgeons to fill them. And there is huge number of patients coming from these areas. I'm taking care of the preparing the list, the surgical list for, and we have at least around 3 to 4 months waiting list for surgeries and of patients that we cannot really do surgery from for them. They're still waiting, and majority of them they are outside of Riyadh. Is there hope for other centers to host fellowship in Saudi Arabia? Yes, some centers are trying, but they, there is no point. If you want to do fellowship, it's better to do it outside. But yes, they are planning to open some fellowships in Saudi Arabia, but I don't understand the reasoning, to be honest. Because there is something you have to understand. Fellowship in cardiac surgery does not mean fellowship like outside. You'll still be doing the same thing. What you'll see in fellowship is exactly going to be the fellowship that you'll see, the cases that you see here. And you'll still do the same thing. But only in very few selective fellowships that it's going to be different, like congenital or maybe robotic. But majority, like cabbage, whatever, all of that, you'll be doing the same thing. It's about more volume. So instead of seeing 5 cabbage cases or 5 mitral cases a month, you'll be seeing 30, 60 mitral case a month. Or so that's how it's gonna. And sometimes you just need the paper for the fellowship to get accepted, especially in tertiary centers, as they will not accept even if you are Saudi graduate from the program. Sometimes they will not give you the title of consultant, like in military hospitals and National Guard in King Faisal. They will not give you the title of consultant if you are a graduate from our local program. Any other question? يعطيكم العافية. Thank you everyone for attending. And these are my contacts if you have any other questions, if you are interested in research or elective rotations. If you have any questions for other centers other than Riyadh, I have good contacts with the majority of residents in Kingdom. Thank you. See you, inshallah.